So next we have a pediatric case along the same vein, presented by Dr. Tiarni Templeton. Tiarni is an Immunology and Allergy Fellow at the QCH, who has dual training in Immunology, Allergy, and General Pediatrics. She's always had an interest in infectious diseases and immunology and has previously contributed to research on primary immunodeficiency and invasive pneumococcal disease. So thank you. We'll welcome Tiarni to present.
Morning. Thank you for having me. I'm going to present, a pediatric case along, the same lines of HLH, but hopefully it might be a bit of a contrast to our adult case. So, starting with something that I hadn't heard of before this case, maybe it is more common in adults, so some of you might be familiar, but clippers. And so chronic lymphocytic inflammation with Pontine perivascular enhancement responsive to steroids. So there is an ongoing question whether this is a distinct sort of entity in itself or whether it is actually a radiological and clinical phenotype of another underlying condition. So our case, sorry, post-viral. We had an 11-year-old female who was referred to the ED from her private neurologist. Her mum had taken her to the private neurologist because she'd had sort of this subacute 6-month history of symptoms, which began initially with diplopia. So was complaining of double vision. Mum took her to the optometrist. She got some glasses and mum thought things had improved. She reported that things did improve a little bit, but actually did have ongoing double vision despite glasses. And then over the last couple of months, there had been increasing sort of clumsiness. She was dropping the ball at touch football. And she also had some new anxiety and emotional lability and school refusal. And then in the week or so leading up to her presentation, her mum had actually noticed that she was ataxic, so walking like a drunk person when she dropped her off to school, and also had noticed that her right eye was sort of turning in. There's also some mildly slurred speech when you drill down further into the history. So when you saw her in ED, she was otherwise well-grown female. She was afebrile, and her obs were stable. She was quite anxious, but she did have abnormal neurology, so lots of cerebellar signs. She had some rotational nystagmus. She had truncal ataxia and fast pointing and dysdiadokinesia. She had ongoing binocular horizontal diplopia, and she had a review with OPFAL. There was no optic disc swelling, but when she was looking to the left, she did have this restricted abduction consistent with a cranial nerve 6 palsy. So she went ahead and got her urgent MRI. And with this, you got quite a definitive report from your friendly radiologist saying that there's obviously these multiple areas of high signal intensity and that this was consistent with the diagnosis of clippers. And they've even given you suggestions of how to manage it, including doing an LP and giving high dose methylpred. So no clinical correlation required. And so the ED team at this stage discussed with the neurology colleagues at the Children's Hospital who had suggested that they should go ahead and do an LP, but would like them to hold off on the steroids for now to do a few more investigations, and thought that Clippers is quite actually a rare disease, particularly in children, and other neuroinflammatory syndromes are more common. So things like anti-MOG and other antibody like Aiden and things would be more common. The patient was also discussed with the ID team, who suggested some extended viral screening and PCRs on your LP. So the LP at the start looked pretty unremarkable. So our opening pressure was okay. We had slightly low glucose, and our white cell counts was mildly raised at 16. Um, but otherwise, gram stain was negative. The full blood count just had a sort of incidental thrombocytopenia, which actually corrected on repeat testing, and the blood film was unremarkable. She had a mildly elevated LDH, and her CRP was normal. Whoop, wrong one. So after the LP results came back, the decision was that this was likely a anti-MOG, and the neurology team requested that the patient be commenced on IV methylpred for 5 days, with a plan to probably drop down to oral post. The patient did have a significant improvement, but not complete resolution of symptoms. And she ended up being, I should have mentioned, sorry, she was at a peripheral hospital, but she was discharged home on day 5 with 50 milligrams of prednisolone ongoing, and was arranged to be seen the next week in neurology clinic to follow up the results and her progress. When she was seen in the clinic, they noted that she had improved but had ongoing nystagmus, diplopia, and intention tremor. So the rest of the investigations had come back by that stage, and it was all negative. At this stage, the neurology team had looked further into clippers. And so, as I said before, it is generally very rare in children, and there's more research going on to whether it is its own distinct entity, or whether it is sort of an overlap. However, it generally is a diagnosis of exclusion. So you need to exclude all kind of hematological malignancies, vasculitis, autoinflammatory diseases. And then in further research, there's been quite a few case reports of clippers in children, but the majority of those have actually then been found to be a CNS HLH. So not truly clippers, as it is a underlying cause. So with that, the neurology team consulted immunology to say, and hematology, I should say, to say, is it HLH? And I guess this is where it gets a bit tricky. So as we saw before with our criteria for HLH and the HLH04 kind of criteria, which was based on pediatric patients as well, have, as you can see here, some either a molecular diagnosis or the criteria needing 5 of 8. And with our patient's investigations, we then added on, or she had some repeat bloods done looking at her ferritin and triglycerides, but they were all unremarkable. So at this point, the immunology team we'd ordered NK, so perforin, by flow cytometry, and also genetic testing for familial HLH, but that was going to take a couple of weeks to come back. So our perforin expression had come back maybe the next week, and it was normal. So as you can see, compared to the travel control in the patient, we have got intracellular perforin expression. However, it's important to note, I guess, with familial HLH, there's lots of different causes, but if you have obviously perforin deficiency, then these basic kind of NK studies will be abnormal. But if you have a issue with further down the line, then you may have normal expression of perforin, but actual functional studies may be abnormal. So then our genetics came back, and we got a hit on one, so UNC 13D, we had a pathogenic variant. And then we've also got a variant of uncertain significance in another allele. So with that, the thoughts from the team was this probably was a isolated neurological or CNS HLH, but we need to do more work to try and upgrade that VUS and also do some more functional studies. However, given the research and the case reports that had been seen, it was thought that it'd be necessary to continue treatment and also to start treatment for HLH with a modified protocol. And so the patient was started on dexamethasone and intrathecal methotrexate. Was also given prophylactic IVIG, fluconazole, and Bactrim. And in terms of monitoring, it's obviously very tricky. We don't have any of these peripheral blood markers of systemic inflammation to monitor. So the only thing we have is clinical and MRI. So repeat MRI had just showed stable lesions, and clinically, patient had remained the same. We then got some of our other studies back. So these are send away tests. So NK cell degranulation. And so the VUS and the mutation that we saw before in UNC-D is responsible for the protein MUNC, which is involved in sort of the actual granulocyte release. So for the granule to actually bind to the wall and be released, it's necessary to have that protein. And so in absence of that, despite having perforin contained within your NK cells, you're unable to release it. And so this study here, this looking at degranulation, so we look at CD107A, which is basically a surrogate because it's a marker that's on the cell surface that's released when the granule binds with the cell membrane. And looking at that, we could see that this was consistent with the diagnosis of UNC-D deficiency. So with our patient, we had sort of very limited expression compared to our travel control. This was further confirmed by a Western blot, which was performed on our patient and a control, where you can see that there is no expression of the MUNC13 protein. And so with that, our VUS was upgraded, and now the patient had a biallelic mutation in UNC13D. And this was consistent with a diagnosis of familial HLH3. And there's actually a known association with familial HLH3 with isolated central HLH. So they tend not to have systemic symptoms. And then management-wise, we'll just touch on briefly, but once we have the confirmed diagnosis, when you have that sort of biallelic mutation, then your risk of recurrence and progression to systemic HLH is very high. And so there's poor reported outcomes without transplant. And with transplant, you can either get an improvement or at least stable defects. So the baseline neurology that she had would remain, but hopefully would not progress. So the patient did proceed with a transplant. So she underwent a matched unrelated donor transplant, and she did reasonably well, actually. And she had engraftment on day 18. She got a mixed chimerism, but she has not had any further relapses and is currently well and several years down the line now. The only thing is we have difficulty revaccinating her and monitoring her due to significant procedural anxiety post all of this, which is probably not that surprising. But that's it for me. So I'll hand over to Pete to take us through HLH.
Thanks, Tiarni. Another great presentation.